I've been dispatched today to a 41-year-old female, Sandra. She's been presenting with a severe headache today. The onset was about 30 minutes ago when she woke up, and she describes the pain as similar to her usual migraines, just a bit slightly worse today. She's had no recent trauma, she's usually fit and well, no exposure to any chemicals, no previous medical history, doesn't take any current medications, and is only allergic to penicillins. She has no associated nausea, vomiting, dizziness, photophobia. And I'm just going to do an opening QRC assessment. So the onset, when did this start today?
About half an hour ago.
Okay. And is there any provoking or relieving factors? Does anything make it better or worse?
Resting makes it feel better, and moving around, it hurts.
Okay. And do you feel the pain anywhere else? Does it go down into your neck, or is it just in your head?
Just in my head, behind my eyes.
Okay. And can you describe that pain?
It's about a 6 out of 10.
Yeah. And is it an ache or a stabbing pain, or?
It's just behind my eyes.
Yeah. Okay. And you said you often get migraines. How often do you get those?
Every couple of months.
Yeah. Okay. My outsider has previously gained a set of vital signs for me, and they're all within normal limits. There's no abnormalities detected there. So we're now going to sort Sandra's pain out and give her some pain relief. So I'm going to give paracetamol, ibuprofen, and tramadol. She said previously that she's only allergic to penicillins. Is that right? You're not allergic to anything else?
No allergies except for penicillin.
Cool. And you've had paracetamol, ibuprofen, and tramadol before?
Yes.
And they were all good? Yeah. Cool. Okay, so just going to go through the contraindications. So you're not pregnant in your third trimester at the moment?
No.
She's greater than 12 years old and has no current paracetamol poisoning. So just going over the dose, so because Sandra's less than 80 kgs, I'm going to give 1,000 milligrams of paracetamol, 400 milligrams of ibuprofen, and 50 milligrams of tramadol. So my offside is just going to sort that out now, and I'm just going to perform a fast test to rule out potential for a stroke. So I'm just going to do a few things. So looking at Sandra, I don't notice any facial droop. Do a big smile for me. Okay, no facial droop. So I'm just going to test arm strength. So can you squeeze my hands? Got equal strength in both hands. And can you hold your arms out in front of you? And close your eyes and keep them there. Cool, so that's all good. And Sandra's been talking to me today, and I haven't noticed any slurring of her speech. So I'm now able to rule out a potential for a stroke as a differential diagnosis. I'm just doing the Brzezinski's test, which is a test for meningitis. So I've got Sandra lying here on her back. Are you able to let me know if you've got any pain when I do this? I'm just going to flex her neck here. Is that painful at all?
No.
Okay. And I didn't notice any involuntary movements of her knee or hips. So if that had flexed when I had done that, that would be a positive sign. So it's a negative sign for Sandra, along with the fact that she has no neck stiffness. That's right.
Yes.
And she didn't have any cervical or thoracic spine pain as well. So now I'm going to move on to the Koenig's sign. Do that test, which is also a test for meningitis as well as subarachnoid hemorrhage. So I've got Sandra still lying on her back. What I'm going to do is I'm going to flex your leg up, and you let me know if you have any pain when I do this. So, turn the leg up, and as I straighten it, don't notice any resistance there. So that's a negative test as well. And you didn't have any pain down your spinal cord when I was doing that?
No.
Oh?
No.
Okay, so that's a negative test, so don't think it's meningitis or subarachnoid hemorrhage. So now I'm going to test for temporal arteriitis. So I do this by a few things. You said you don't have any pain in your temples?
No.
No? Okay. And she's already described the pain, so it's not a persistent throbbing pain, it's not there in the temples. Is it tender when I touch here on your temples?
No.
No? Okay. And I don't feel decreased pulsation there. So I can rule out temporal arteriitis as one of the potential differentials. So now I'm going to do the cranial nerve test. This is testing your facial nerves. Is that okay? It involves a few different touches and whatnot. Okay, so the first one is the olfactory nerve. This is to do with smell and is a bit too hard to examine pre-hospitally. So second is the optic nerve. This is checking visual acuity. So I'm going to check your pupils. So just having a look. So both pupils are the same size, both reactive to light. And can you read something for me? So can you read this for me?
Emergency medical technician.
Okay, cool. So the third cranial nerve is the oculomotor nerve. So I'm going to do this by testing. If you just watch my finger. Yeah, so when I did this I didn't notice any nystagmus or restricted eye movements. Did that make you feel dizzy at all, or did you get blurred vision when you were doing that?
No.
Okay, cool. So the fourth cranial nerve is the trochlear one, which we've previously assessed by assessing eyes already. The fifth is the trigeminal, the ophthalmic and maxillary and mandibular nerve. So this is assessing your sensory, reflex and motor. So I'm going to lightly touch different places on your face and you let me know if you have any decreased sensation, if it feels the same or different on different places. So you feel that?
Yes.
Same on both cheeks?
Yes.
Same on both sides of the jaw?
Yes.
Okay, cool. So 6 is abducens. So I previously assessed this again with assessing her eyes and pupils. So 7 is the facial nerve. So I assess this by assessing symmetry and power. So there's a few tasks I want you to perform for me. First is, can you raise your eyebrows? Cool, so that's all good. Close your eyes for me. Yep. Blow your cheeks out. Yep. Can you attempt to whistle? Sweet. And closing your lips tight. Perfect. So those all appear normal. So I'm okay with the facial nerve. 8 is the vestibular cochlear nerve. So this is to do with sounds. I'm going to come behind you and I'm going to whisper something in your ear. You let me know what number I say, okay? 6. Alright, so that's good. 9 is the glossopharyngeal nerve. So can you swallow for me? No pain, no difficulty with that? Okay, and a cough. That's all good. And she's been talking to me fine today, so those all normal. 10 is the vagus nerve. So this nerve provides the motor supply to your pharynx. So she's been talking to me normally, so good speech indicates an efficient vagus nerve. And 11 is accessory nerve. So if you shrug your shoulders to me, and I'm going to push down and you try and resist that. Yeah. So that's all good. And 12 is the hypoglossal nerve. So to assess this, it's assessing normality, protrusion and strength inside your mouth and your tongue. So you poke your tongue out for me. Yep. And put it against your cheek and I'll feel, yep, it's good strength. Good strength. Cool, so that was the cranial nerve assessment. So now I'm going to go through the red flags checklist for headaches in our pocket CPGs. So this is just to rule out any red flags and reasons why we shouldn't leave Sandra at home today. So the red flags are headache or neck pain following neck manipulation. So that's no neck pain or neck stiffness. That's a no sudden onset of severe headache. Temperature greater than 37.5. Persistent vomiting, focal neurological signs, altered level of consciousness, and worsening headache following recent trauma. She doesn't take an anticoagulant or have a bleeding disorder. Already ruled out temporal arteritis. Hypertension during pregnancy, she's not pregnant. Doesn't have a previous history of intracranial bleeding. She doesn't have a family history of cerebrovascular abnormalities. No onset during sexual activity. The orange flags, however, is migraine with symptoms different to usual. So because Sandra does usually get migraine, she does think this is her usual migraine pain, but slightly different to usual as it's a bit more severe. So I recommend that Sandra sees the doctor within 12 hours. Is that okay? Do you think you'll be able to get to your GP within 12 hours? Yeah. Okay. So we're happy to leave Sandra at home today. So I'm going to go through the non-transport checklist. So patient's been fully assessed, set of vital signs have been taken, and nothing has been found there that's abnormal. Serious illness and injury has been excluded. We've been through the red flags, none of those were present. Patient seen to mobilise as per usual, we've seen that already. And I'm going to give Sandra an explanation of when she can seek further help and what she can do now. And I've already explained that we're going to leave our PRF and our paperwork copy with her and see how she can access that later on and give that to her GP. So my recommendation to you today is just rest up, take paracetamol and ibuprofen that you said you have here at your house every 4 hours if that's necessary, and see your GP within 12 hours. And I'll give you that sheet with the signs and symptoms to look out for if anything worsens. All the best.
Thanks.
A I've been dispatched to Sandra today, a 41-year-old female who has had a nosebleed. She was on a long car trip today. It is quite a hot day and the aircon was going and her nose just started bleeding, so she's pulled over. It's been bleeding for about 10 to 15 minutes, so she called an ambulance. I've instructed her to keep that direct pressure on the fleshy part of her nose for 15 minutes and then we'll reassess. I've also told her that she should spit out any blood that comes down in the back of her throat, so we don't want that coagulating in the back of her throat there. And also if you swallow it can make you feel pretty gross, so I've got the anaesthetic bag there for that. She has no previous medical history. She's had this happen a couple of times before, also on hot days, and that's been in the past couple of years. She's already explained she's never had any nasal or cranial surgery. She's not on any regular medications, not on any anticoagulants. My ulcerator is already done a set of vital signs. They've all come back within the normal limits, no abnormalities, so we can rule out hypovolemia because you can develop that with a great loss of blood, which can sometimes happen with a nosebleed. She's had no recent trauma, and we're just going to be waiting 15 minutes to see if the bleeding stops. So it's been 15 minutes with Sandra applying direct pressure to the fleshy part of her nose now. So now we're going to reassess and see if the bleeding has stopped with the direct pressure. So if you just remove that. Okay, so I see there's still a continual flow of blood from the left nostril. So again, doesn't look like any blood's coming out of the right nostril. So just keep that pressure on there now, the head tilted forward. So we're going to have to escalate from mild epistaxis to moderate epistaxis now. So I'm going to use a pharmacological intervention and give intranasal adrenaline to try and stop. So now I'm going to draw up the adrenaline to give. So we're going to be drawing up to make it 1 in 1,000 adrenaline. I'm going to be giving 2 mils, which is 0.2 milligrams into each bleeding nostril. In this case it was just the one nostril. So I'm going to start off with checking my adrenaline. So this is adrenaline 1 milligram, 1 mil, 1 in 1,000. It expires in September 2019, so that's in date. Looking at the ampule, it's all good. I'm just going to get my offsider to drug check that for me. So I've got all my gear here, all ready to go. Cool, offsider drug checked it. Okay, so we're going to start off with drawing up 9 mils of saline. I'm just going to get the offsider to drug check that as well. So sodium chloride 0.9%. 90 milligrams in 10 mils, and that expires in August 2020. Get offsider to check that as well. Cool. So I'm going to draw up 9 mils. Of the saline, and then my drawing up needle. Adrenaline. So we're drawing up the 1 milligram. Cool, so I'm going to give that a bit of a shake. So now I've got the 1 milligram of adrenaline and the 9 mils of saline in here, which makes that 1 in 10,000. So next thing we're going to do is label the syringe with adrenaline sticker. We don't want getting that mixed up with anything. So I find it a bit easier when giving it in a smaller syringe. You can give it in the 10 ml syringe, but a bit easier this way. So because we're just going to give the 2 mils, because it's just the one bleeding nostril, I'm going to draw out 2 mils. And again, I'm just going to label this syringe. So now I'm going to attach it to the mucosal atomizing device. Just attach that onto the end of the syringe. Prime it until it comes out a bit out the top, and then we're ready to go. Okay, so I've got the intranasal adrenaline here already drawn up. So we're going to give this. So first we're going to explain to our patient what we're going to do. So I've got some adrenaline here. This is we're going to squirt this up your nose to see if it's going to try and constrict those blood vessels and stop the bleeding. So it's a bit of a funny sensation, but what we're going to do is I'm going to say 3, 2, 1. On 1, I'm going to squirt this up your nose. And if you take a big sniff while I do that on 1, that's going to go up there. Is that alright with you?
Yep.
Okay, so before we do this, we're going to get you to spit out any blood that you have that's run down the back of your throat, you have in your mouth, and also blow your nose to get rid of any blood clots. Yeah.
Allergies.
So just before I give the drug, I'm also going to check again for any allergies to anything. Allergic to anything?
No.
Cool. Okay. So we're going to give this. So I'm just going to put that in your nostril. Purpose of this, I'm not. But and then on 1, you're going to sniff, and I'm going to push it. So 3, 2, 1. So we do that, and then you just also hold that there, and we're going to wait 15 minutes again and reassess if the bleeding has stopped after our iron adrenaline. So it's now been 15 minutes since we gave the intranasal adrenaline, so I'm just going to check and see if that's worked. So you remove the towel, have a look. Don't see any blood, it's not dripping out at all, so I think that that's been successful. If it wasn't successful and it was still bleeding, we could give another 0.2 milligrams of adrenaline into the 1 in 10,000 mixture into the bleeding nostril. And if it continued to bleed, we would request an R50 backup, as they might have a nasal tamponer device, or a small ET tube also works by inflating that inside the nostril. So just recommendation to Sandra is that when you get to your hometown, I know you've been travelling today, when you get back there, if you can see your GP, just because this is a bit out of the ordinary and has been bleeding for unknown reason today, do think it is due to being in a hot car, having the aircon blowing with the dry air. But if you just go see your GP for a checkup, and recommendations for the rest of today: avoid hot showers, avoid hot drinks, hot food, and avoid blowing your nose for as long as possible, because you don't want to rupture those clots that are stopping it from bleeding at the moment.